Hello, welcome to my YouTube channel. Today I am going to discuss with you regarding the diabetic management, especially pharmacological management of diabetes. From this video, I would like to discuss with you definition of diabetic and how you're going to diagnose the patient is diabetic, what are the symptoms of diabetics, and what are the pharmacological option you will have for the management for the diabetic, and especially the oral hypoglycemic agent and old agents and new agents I'm going to discuss in this video. So we'll move on to the today topic, management of diabetics. First of all, I would like to give definition what is the diabetics. Diabetes is a chronic metabolic disease characterized by elevated level of blood glucose, which leads over time to serious damage to heart, blood vessels, eye, kidney, and the nerves. You can see from here when your glucose in the blood is not in optimal level, if it is stand for long time, then it can damage to your vital organs like heart and kidney, nerve system, and the blood vessel. So with the time you will have the lots of complication which is uh, due to this diabetes mellitus. So it is very important to control your blood sugar and keep your blood sugar in the optimal uh, optimal level, right? So the this slide actually I'm going to discuss with you what are the common symptom of the diabetes. These symptom we call as osmotic symptom as well. So one is a polydipsia, polyphagia, polyuria, and the nocturia. Polydipsia is a excessive thirsty in abnormal urge to drink the fluid at all time. It's mean when your patient will explain you, he or she has excessive thirsty and they want to drink some more water for that's one actually we can consider as a polydipsia. So polyphagia is eat the excessive amount of foods. It means the patient will complain you, not like previously she will or he will have the excessive hunger to foods. So other one is polyuria, passes the excessive or abnormal large amount of urine in each time, and the nocturia is a different one. The need for the patient to get up at the night on the regular basis to urinate. These are the we call as osmotic symptom, and which is more common in the diabetic patient. So there are lots of other symptom which is relevant to the diabetic complication, but I'm not going to give in details in this video. And you there are lots of other comorbidities like due to diabetes neuropathy, diabetes nephropathy, and the macrovascular and microvascular complication. Due to those things, the patient might have the various of symptoms, right? So this slide actually I just want to highlight in here how you going to diagnose the patient for the diabetics. Actually diabetic diagnostic criteria. Suppose you are when you get the patient with the osmotic symptom like polyuria, polydipsia, polyphagia, then impaired of one of these investigation, so you can diagnose easily that patient has diabetic mellitus, right? So suppose if your patient does not have any symptom, but if you get the impaired one of these in blood test, then you have better to repeat it and confirm it, right? If you get the fasting blood sugar, it is if it you can say it is normal if it is less than 100 milligram per deciliter. If you get the 2-hour ppbs for the normal, it should be less than 140 milligram deciliter. If you take the HbA1c, it should be less than 5.7. You can consider it as normal HbA1c. What is the diabetic range of fasting blood sugar? We can say even if your fasting blood sugar more than 126 milligram per deciliter, yeah, that's patient might have diabetes, right? 2-hour ppbs more than 200 milligram per deciliter, yes, that patient might have diabetes. HbA1c more than or equal 6.5, definitely that patient you can say having diabetes. So one abnormal test, uh, and if the patient has asthmatic symptom, you can simply diagnose that patient definitely has a diabetic. If you have only one abnormal test without any asthmatic symptom, then better to repeat it and confirm it, right? Then pre-diabetic is a very important one. Why? Pre-diabetic level is, it is not normal, it is not diabetic, it is in between that, and that value was very important, because when you are going to treat the patient with diabetic, our target is to keep the patient at least in the pre-diabetic level during the management. So pre-diabetic level fasting blood sugar is 100 to 126 milligram per deciliter. To our ppbs, we consider as 140 to 199 milligram per deciliter is pre-diabetic. HbA1c can consider as a pre-diabetic 5.7 to 6.4% of percent, we can say as a pre-diabetic. So you can get this idea about how you're going to diagnose the patient with the diabetic, and we will move on the next slide. Suppose now you almost diagnose the patient, that patient has DM, then you have to somehow control this patient's blood sugar, and keep the optimal level. Otherwise, it will have lots of comorbidities with the time, right? So you have to with the pharmacological or non-pharmacological method, you have to keep the ideal uh, target to HbA1c. We can say ideal target to HbA1c is 7, right? But even you can go even less than 6.5. Also, it's a tight glycemic control with suppose your patient is a very young patient and less comorbidities, then physically active patient, then you can give them as a tight glycemic control like HbA1c less than 6.5, right? Suppose your patient is a little bit of elderly patient with the comorbidities, then physical little bit of not inactive, then you cannot achieve that much of tight control like HbA1c 7 to 6.5. Even even though that patient, if you can achieve the HbA1c less than 8, that would be enough, right? So that's why actually from this slide I want to emphasize in here, when you diagnose DM patient, during your treatment, your target of HbA1c keep in between 7 to 7 is ideal. If you can go for the further tight control 6.5, less than 6.5, that would be grateful. Even though you can achieve by less than 80, it would be enough if the patient's it's elderly and the little bit of having the comorbidities, right? So that's why our main goal of the treatment during the DM patient. So suppose if you are considering of tight control for the young patient, their fasting blood sugar target would be will be 70 to 110. Then ppbs target would be less than 140 milligram per deciliter will our target, right? Suppose now you are deal with the elderly patient, then your fasting blood sugar target would be less than 130 also enough, right? ppb is less than 180 also would be enough for considering of that elderly patient, right? So you have to keep in mind, definitely if your HbA1c target for the even whatever you know the elderly, if you can achieve by HbA1c 7, that would be great, right? Then if your patient is a little bit of elderly patient, then if you can achieve the HbA1c less than 8, that would be enough. If your patient is young and he is well active with less comorbidities, then you can go for the further um, uh, strengthened control of HbA1c less than 6.5. That's what you have to get from this slide, right? Why I am saying you have to keep the HbA1c in the our target level, because when your patient after diagnosis of your DM, if you cannot achieve your HbA1c less than even 8, so with the long standing, the patient complication will be high, right? If you control HbA1c less than 8, then you can reduce all the complication which is relevant to the diabetes. From this slide, very important, you have just keep in mind, when the HbA1c is going to be high, all these complications like diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, microalbuminuria, these risk will be, you can say sky high when the HbA1c is high. Then you can say, if the HbA1c less than 8, all these complication risk will be, what will happen, low. That's why actually during our treatment plan, we have to somehow keep the patient's HbA1c in bit less than 8, at least, so it would be great to if we can achieve by 7 or less than 7, 6.5. But if you can achieve by less than 8, it will be help to reduce all these risk factors, right? So then actually I would like to discuss with you pharmacological management of DM. When you diagnose a diabetic patient, then you have to think about that patient meal plan also, and you have to think about that one, how you're going to give him a diet plan. It will be dependent on few factors, like patient BMI, then whether the patient young or elderly patient, whether patient physically active or less active, then what are the comorbidities. According to those things, you have to create the separate individual diet plan for the each patient. But I'm not going to discuss about diet plan in this video. I would like to discuss it in separate video. Here actually I'm discuss about all the pharmacological management of DA except insulin. Insulin also is a, I would like to discuss in separate video how you go, what are the type of insulin, what is indication to start of insulin, and all those things in the different video. But here I would like to focus on all the oral hypoglycemic drugs, what are the old drugs, and what are the new drugs which is available in our market, and how you're going to use it, those and etc. Right? So pharmacological management of DA, you can divide it into the actually three category. One is your oral hypoglycemic drug. Other one is a very new drugs, but it is cost is so high, and the administration is oral administration also not available. That one is, we can say, non-insulin injection like glucagon like peptide receptor agonist, right? And other one is insulin therapy, right? Right. Then this slide, group of old and new oral hypoglycemic drug. The biguanides. It's one class of drug is a biguanides, that metformin, and other one is sulfonylurea. Third class is, we can say, alpha glucoside inhibitors, and the fourth one is we call thiazolidinedione, like your pioglitazone, right? This one also little bit of out of market due to its complication. But if you take the HbA1c reduction percentage will be high, like 1.5 compared to the other sulfonylureas and the other drugs, right? Then the what are the new drugs are available in the market is a GLP-1 agonist. We call that glucagon like peptidase 1 agonist. Another one is a DPP4 inhibitors. We call this dipeptidyl peptidase 4 inhibitors. Other newest drug is SGLT2 inhibitors. We can say it as selective sodium glucose transport 2 inhibitors. These drugs are new drugs which is available in our market. These drugs actually old drugs, and which is usually commonly used in these drugs when you are deal with the patient with DA. So we are going to discuss about all these drugs separately and what are the example, and all the extras. So I will move on to the one by one, right? So this diagram also very important diagram. You have to just keep in mind. That this slide I want to explain you your HbA1c reduction percentage with the different drug agents, uh, compare with the different drug agents, right? So insulin has the highest ability to reduce your HbA1c, even though you can achieve more than 4, right? When you increase your insulin dose, you can achieve more than 4 HbA1c reduction percentage by insulin, right? Other one, this one is a very important one. You have to remember these two, because why I'm saying important, metformin and sulfonylurea, these two drugs have same ability to reduce in your HbA1c just by 2 to 2.5. Our all uh, why I'm saying like that, our GPs, when you diagnose a DM, then they would like to start the sulfonylurea rather than start metformin. They might, lots of GPs are thinking the reducing of HbA1c and the control of blood sugar, sulfonylurea is more superior than metformin. Not like that. Metformin and sulfonylurea both have the same ability to reduce your HbA1c by 2 to 2.5, right? Then actually, other thing is metformin has lots of non-diabetic benefits also, like, no, that's why actually we consider metformin is a first line agent for the diabetic. We will discuss all those things when we are going to discuss about each category. Then other one is, as I told you, pioglitazone. Pioglitazone has a HbA1c reduction ability at least 1.5, has 1.5%. And other all the new drugs, like, SGL2 inhibitors, DPP4 inhibitors, GLP agonists, right? All these drugs, new drugs, have the same ability to reduce your reduce HbA1c by 1%, right? All these have same ability to reduce HbA1c by 1%. So you have to understand here, according to our drug category, it has different ability to reduce HbA1c and achieve your glycemic control. So metformin is the, we can say, first line recommended drug agent for the patient with the DM, if there is no contraindication, right? So when you diagnose the patient with DM, irrespective of that patient age, then your first line treatment is metformin if there is no contraindication, right? What are the, why I am saying like that? If you start from the metformin, if you give the metformin to the patient, it can increase the cellular glucose uptake. When the cellular glucose uptake is going to be increased, what will happen for the blood sugar level? Blood sugar level coming down, and you can control the blood sugar level. Other one is metformin is actually increase sensitivity to the insulin. The type 2 DM, they produce enough insulin, but problem is insulin sensitivity will be low. That's why their blood sugar will be high. But if you give the metformin to such a patient, metformin can increase the sensitivity to the insulin, and then the insulin will be working, activity of work will be high. Then you can once again achieve the blood sugar control to your patient. Other one is reduce the hepatic glucose production. When the glucose production is reduced from the liver, then your blood sugar will be low. Not only that, by giving the metformin, you can reduce all the diabetic comorbidities like MI and neuropathies. That's why actually metformin is a first line agent. You have to, without any hesitance, you have to start the metformin with the patient if there is no any contraindication. What are the contraindication of metformin? Is the important one is that patient GFR. If the GFR less than 30, you cannot start the metformin. That is only one contraindication. GFR definitely more than 30 should be there to start the metformin. Suppose if your GFR less than 40, right, less than 40 but more than 30, still you can start the metformin. But we are telling, don't start the metformin for that particular patient, because GFR more than 30 is there but less than 45. Then by giving the metformin, if you do not follow the patient properly, that can worsen his renal condition. But if you still want to start the metformin, if GFR is less than 45 but more than 30, yes, you can start. Maximum dose is 1 gram per day. Other one is, if your patient is severely emaciated and the loss of appetite, then you have to doubt to start metformin, because of metformin also per se, it can increase the patient's loss of the appetite will be loose. That one are those things are we consider as a little bit of contraindication to start the metformin. Right. Then what are the benefit of metformin now? One is a very important one, is promote the weight reduction. This one very important. Suppose your patient is DM with the high BMI. On top of that, if you give this sulfonylurea, the patient weight might be further high, right? But if you give the metformin promote your weight reduction. That will be one of the benefit, right? The other one is it can reduce the HbA1c 2 to 2.5%, like your sulfonylurea. Both drugs have the same ability to reduce your HbA1c, right? Other one is low risk of the hypoglycemia. Those are the benefit of metformin. Right. Next drugs, actually I would like to discuss with you about sulfonylurea. This is a very famous drug, and one of the oldest hypoglycemic agent dating back to the 1950s. Directly stimulate the release of insulin from the pancreatic beta cells, and therefore lowering blood glucose concentration. This is actually sulfonylurea. It's the oldest drugs and very famous drug, still among the GPs. So it can achieve the HbA1c reduction is 2 to 2.5 like your metformin, but it has lots of complication as well, right? We are going to discuss all those things separately. Suppose this picture, I just want to show you how your sulfonylurea work in your body. Briefly, I am just want to explain you. When you give the sulfonylurea, it can bind to the sulfonylurea receptors on the pancreatic beta cells. Then what will happen? It can block the ATP sensitized potassium channel. Then the potassium conductance will be low. Due to potassium conduction low, what will happen? Depolarization will be happen, and when it reaches to threshold level, then the calcium influx will be high. With that, what will happen? Degeneration of the insulin granula will be occur, and the insulin will be released. That's how actually all these sulfonylureas are working in our body. Actually, I'm not giving the much detail regarding this. I just want to highlight in here what are the main steps of the mechanism. I hope you will be understand that how it's going to work in your body, right? Then the sulfonylurea, you can divide it into two categories. One is a conventional agent, and other one is new agent. Conventional agents are, you can say tolbutamide and the glibenclamide and the glipizide. This one also very important duration of action. Glibenclamide is a long-acting sulfonylurea. Its action might be persist more in between 16 to 24 hours. Right? This one we consider as a glibenclamide is considered as a long-acting sulfonylurea. Tolbutamide 6 to 12 hours duration of action. Glipizide 8 to 12 hours of duration action. The newest drugs are available in the market also. One is a glycoside. Duration of action 8 to 12 hours. Glycoside MR 10 to 24 hours. Glimepiride 16 to 24. We can consider this one also long acting sulfonylurea newest drug, and the glipizide ER 12 to 24 hours is the duration of action. Right. Sulfonylurea, its only thing is reduction, ability to reduction of HbA1c by 2 to 2.5, right? But it has a highest risk of hypoglycemia, right? Then it has an impact of weight gain. Those are the side adverse effect of sulfonylurea compared with the other drugs, right? Right. Other one is a thiazolidinedione, your piaglitazone. This one was little previously it was a very famous drug. Now at the moment it is not used in that much in the market and our GP practitioner clinics. So how it's going to work? It is a increase the insulin sensitivity by the acting on the adipose tissue, muscles, and the lesser extent liver to increase the glucose utilization and the decrease the glucose production. Thiazolidinedione, when you give it will affect on your liver and reduce the gluconeogenesis. Due to that, as a result, what will happen? Reduce your blood sugar level. When it act on your muscle, it will increase the glucose uptake with the from the muscle. If the glucose is going to be utilized, then what will happen? It will reduce the blood sugar level, right? Then the thiazolidinedione can works on your adipose tissue and increases the adipogenesis, fatty acid. Then fatty acid uptake will be high. Then the lipogenesis will be high. Then the glucose uptake will be high. Due to that reason, plasma free fatty acid will be low, and the reset of glucose fatty acid acid will be high, and it will once again affect your liver and reduce the gluconeogenesis. Right, that how your thiazolidinedione is working in your body and control your blood sugar. Right. This right, actually I just want to tell you about what are the adverse effects of thiazolidinedione and the contraindication. Adverse effects are weight gain is a very common one. Then if your patient is high BMI, if you give thiazolidinedione for that same patient, then that patient once BMI will be high again, right? Other one is due to that it has a fluid retention ability. If you give the patient thiazolidinedione with the patient with the heart failure, then heart failure might be worsen. Other one is a risk of fracture can be high. Other one is if there is a impact in the bladder cancer, right? Other one is macular edema can also worsen. What are the contraindication of giving the thiazolidinedione? Is renal failure, you cannot give. Pregnancy, you cannot give. Previous history of bladder cancer, you cannot give. And the class 3 and above heart failure patient, you cannot give because of that fluid retention, right? Then this one is a newest drug. I'm now going to discuss with you regarding this GLP and DPP4 and SGL2. What are these drugs and how it's going to work in our body? Actually, we can say GLP, DPP4 drugs, incretin based therapy. What are these incretin based therapy? From this slide, I am going to discuss with you regarding some biochemistry, how you are when you take your food, when it's break down glucose and how it's pancreatic beta cells and alpha cells are working and producing insulin. Those things I'm going to briefly discuss from this slide. Then you will be understand our newest drugs, how it's going to work and where we going to target in this patient. Suppose now when you take the oral intake, then it will break down to glucose. Then when it is break down to glucose, there is our small intestine brush border, they will absorb, right? Then when the glucose absorbed to the small intestine through our brush border, from the gut they will synthesize another release two enzymes. We call that GLP-1 and GIP. When these enzymes are released, it has impact on your pancreas. Then from pancreas it will stimulate your beta cells and producing the insulin, when the insulin is produced, all the glucose uptake will be high in the your fatty tissues and muscle. Then your blood sugar will be keep under control, right? Then as well as it has a impact on your alpha cells and reduce the glucagon production, and due to lack of glucagon, glucose production from the liver will be low. But there is another enzyme we called as the DPP4 enzyme, standing for the dipeptide peptidase enzyme. This enzyme can reduce the activity of these two enzymes, right? That's why actually I have emphasized in here, rapidly inactivate to GLP-1 and the GIP. What happened when this enzyme is start its action, all the GLP-1 and GIP enzyme action will be suppressed. Due to that reason, this beta cells activation and won't be happen, then insulin won't be released, then your blood sugar will be high. That's why actually pharmacology, they have uh, produce another special drug which can aggregate this GLP-1 enzyme, and other one is we are targeting here, we suppress this DPP4 enzyme, right? We will go step by step how this drugs is working in the next slides. So GLP-1 receptor agonist, GLP-1 receptor agonist we call a glucagon-like peptide. This is a newest drug. What are the benefit? Benefit, you can achieve the weight loss. That would be good benefit, right? Other one is it has an impact on cardiovascular benefit also, and the hypoglycemia risk will be minimum. A reduction HbA1c you can achieve by 1 to 1.5, right? Disadvantage of GLP-1 receptors, it is actually expensive. Another one is subcut administration is need, and the GI side effect will be high, and the risk of pancreatitis also be there, but it is not that much of common. That is a little bit of rare condition. So what are the drugs of GLP receptor agonist? We can divide it into the short acting and the long acting. The short acting we can say exenatide and the lixisenatide are short acting drugs, and long acting drugs you can see from here. Exenatide, dulaglutide, semaglutide, and liraglutides are the long acting drugs, right? Then when you give these drugs, actually it is not available at the market, or it has a subcut administration. That's why actually it is a little bit of there are controversies of us giving these drugs, because the patients sometimes they are not willing to go for this subcut administration, we compare with its expensiveness. Then that this drug is still not used commonly in our region, but it is very commonly used in the European regions, because of it has lots of benefits, and compared with other drugs. Now how it's going to work, from this slide I will show you. When you use this GLP GLP receptor agonist, right? GLP receptor agonist for diabetic patient, it will enhance the action of this GLP-1 and GIP. When the when it's enhanced this action of these two enzymes, then what will happen? It has an impact on your pancreas, and from pancreas it will increase stimulate the beta cells and the alpha cells. Then from the beta cell it will release the more insulin, then the glucose uptake will be high, then you can achieve the can control the blood sugar level. The same as it has an impact on your alpha cells, and once again glucagon production will be low. Then due to that reason, from the liver glucose production will be low. Due to that reason, you can achieve the blood sugar control by giving this GLP GLP-1 receptor agonist, right? That's actually I just want to emphasize from here how these drugs is going to be work in our body, right? Right. Then the other one is DPP4 inhibitors. DPP4 inhibitors, we can say the dipeptidyl peptidase 4 inhibitors. It is working, we are target from here, DPP4, because as I told you previously, when this DPP4 enzymes comes, it can suppress the GLP-1 and the GIP enzyme. When the GLP-1 GIP enzyme are suppressed, as I previously explained you, beta cells stimulation and insulin production will be affected. Then the lack of insulin, due to lack of insulin, what will happen? Your blood sugar level will be high. Then the pharmacology, they have developed the drugs, DPP4 inhibitors. Then when you give these drugs, it can inhibit this enzyme and uh, keep the GLP-1 and GIP in the active level. Then, as I told you previously, it can reduce your blood sugar and control the blood sugar in that particular patient. So, what are the example of DPP4 inhibitors? Are sitagliptin and the linagliptin. Linagliptin and the sitagliptin maximum dose is 100. Actually, you can give 50 to 100 once a day. Linagliptin 5 milligram per daily, and the saxagliptin 5 milligram per daily, right? Except linagliptin, other all drugs you have to adjust according to the patient renal function. Linagliptin, you don't want to adjust the dose. It has a renal protection ability rather than sitagliptin and saxagliptin. So it is a well recommended drug, right? And DPP4 inhibitors, when you going, it has no risk of hypoglycemia. Hypoglycemia risk will be very low by giving DPP4 inhibitors, and the weight may be loss or neutral. Good tolerance is there, and the neutral effects on the cardiovascular outcome. As I previously mentioned, you need to dose adjustment in the renal impairment patient except linagliptin. Right there, those things you have to know about the DPP4 inhibitors. Right. Other one is SGL2 inhibitor. We can say simply selective sodium glucose transport 2 inhibitors. How this going? This is a very important drug. This is a newest drug which is available in our market. It has a lots of benefit compared to other drugs, especially for the renal protection and the cardiovascular protection wise. It has a huge impact on the patient. So it is very same as it has some kind of adverse effect also. We will discuss all those things. I would like to explain how this drugs is going to work in your body. Our nephron, it will the first segment of the proximal convolutional tubule, there is a special transporter which is located in that area. We call this transporter selective sodium glucose transporter 2s. From this uh, trans transporters, what will happen? They can absorb the all 90% of glucose from the fluid which is filtered through the glomerula, right? So we are going to inhibit the action of this transporter by giving the some drug. Then you can achieve the 90% of glucose reabsorption you can reduce. Due to that reason, what will happen? The fluid which is passing through this proximal convolutional tubule and loop of Henle and this ultimately you will get the excessive glucose urea with the urine, because of without absorption of the glucose, all this glucose will be excreted to the from the body with the urine, and you will get the glucose urea, right? So how I just want to emphasize in here how this drugs is working in your body. It will affect on the first segment of the proximal convolutional tubule, which is located in the SGL2 receptor, and we will block that receptor. Due to that, as a result, what will happen? It can't absorb the glucose from the from the fluid which is passing through that proximal convolutional tubule. Due to that reason, you can achieve 90% of glucose reabsorption will be cut off. That's why actually you can get the good glycemic control for that particular patient by giving the SGL2 inhibitors, right? Sorry. So what are the benefit of SGL2 inhibitors? Are reduce the blood glucose level, and it has a huge impact on your weight loss also. We can gain the moderate weight loss, right? Very important one is a improve your cardiovascular outcome. That's one is a very important benefit from this drug. Other one is improve your renal outcome, also very important benefit is there. Other two benefits are improve your blood pressure and the low risk of hypoglycemia. What are the example which is available? There are two drugs available. Empagliflozin and the canagliflozin are the two drugs. Empagliflozin 10 mg per daily doses you have to give, and canagliflozin 100 mg daily doses you can start, right? What adverse effect of SGL2 inhibitors are? Risk of genital infection due to glucose. As I told you, when you give these drugs, it will reduce the glucose uptake, reabsorption from the glomeruli, right? Then what will happen? All the glucose will be excreted with the urine. Then the glucose urea can happen. Due to this glucose urea, what will happen? Sometimes the patient, they will get the genital infection. From for the female, they might have the candidiasis. So for male, they might have the balanitis. If your patient complain of having the recurrent UTI or the recurrent candidiasis or balanitis for the female male patient, you have to withdraw the drugs. You cannot continue with that drugs because of the recurrent infection. And risk of volume depletion. How it will happen? When the when we block the SGL2 receptor, then glucose reabsorption will be low, right? When the glucose reabsorption, when it is low, then all the glucose will pass with the urine. Same time, what will happen? Glucose will drag all the fluid, and that's why actually fluid also polyuria will be happen in this patient. Due to that reason, your patient fluid little bit of depletion, volume depletion can be happen. Then you have to advise your patient, when you prescribe such a drugs to patient, at least they have to take the adequate oral hydration, 1.8 to 2 liter per day. Otherwise, they might have the dehydration due to that polyuria. Because of it, there is a impact on the risk of volume depletion of that particular patient who's on the SGL2 inhibitors. Other one is risk of decay also there, right? Okay, let's move on to the one case. From this case, actually, I want to show you how you're going to start the antihypoglycemic drugs for the patient, and what are the things you have to consider prior to start your treatment. Then those things I will cover from this case. Suppose 38 years old female patient with the high BMI more than 27 had asthmatic symptom. Then due to the asthmatic symptom, she has done the fasting blood sugar HbA1c. Fasting blood sugar came as 320 milligram per deciliter. HbA1c is sky high, more than 9%. But there is no any microvascular complication of that patient. Then how you going to manage this patient? The things you have to understand in here: this patient 38 years means young patient with a high BMI. Those are a little bit you have to consider prior to start your treatment. And the HbA1c also not in our target level, and it is on the high, and the fasting blood sugar also 320. So how you going to manage this patient? Our first line drug is a metformin, because there is no any contraindication to the not to start metformin, since she is obese patient, and young patient. You can first, as first line drug, you can start the metformin for this patient. Then as a second line drug, when once you start the metformin, there are lots of uh, but the benefit for that patient. You can promote the weight gain, weight reduction of that patient, and the increase in the insulin sensitivity by giving the metformin. Those are the lots of benefit regarding the metformin. That's why you have to start as a first line drug for the metformin. On top of that, you have to select about another drug to control the patient fasting blood sugar, and the keep our HbA1c in the our target range in between 7 to 6.5. Since patient is young, you have to go for the you can go for the actually tight glycemic control as well. So compare with how you going to select the which drug will be a most suitable as second line drug, because of you have to think patient here. BMI is high, then you have to think about some kind of agent which is not promote the weight gain. The most then you can add to this patient is as second line drug. First is GLP-1 receptor agonist, or SGLT2 inhibitors you can add. But compare with the subcut administration and the expensiveness, then the patient might not willing for this GLP-1 receptor agonist. Then you have to add the second line agent as a SGL2 and inhibitor, like your empagliflozin. You can add 10 milligram per day, and you have to educate regarding all those adverse effect of empagliflozin. If she has such kind of complaint, you have to definitely withhold that drugs also. Then with that, if you cannot achieve the HbA1c in your target level and the fasting blood sugar in your target level, you have to keep around another third drug. That one is you can add as a third drug you can add DPP4 inhibitors. Inhibitor like linagliptin is a or sitagliptin also you can add. Then you have to give the good diet plan for this patient, and somehow get your target HbA1c around 7 to 6.5. Can you start as a second line drug for this patient sulfonylurea? No, because the sulfonylurea and it has a weight gain. If you give sulfonylurea on top of other drugs, then the patient might have gain the more weight. So you can't start the sulfonylurea for this patient. Pioglitazone also same. It has a weight gain problem. So the first thing you have to give the metformin. If you want to start a second agent, you can go for the GLP-1 agonist, so SGL2 receptor inhibitors. On top of that, then you can think about giving the DPP4 for this patient.